So welcome back, everybody. Welcome back to the third and final session. My name is Nadine Ferris France, and I'm the Executive Director of the Irish Global Health Network. I'm really delighted to be moderating this session, which brings us from the last session of hearing the amazing work of all of our partners overseas back to Ireland to look at the education that we have, the global health education here. As an adjunct lecturer myself in Trinity, in UL and in Cambridge, now Maynooth, I've experienced firsthand some of the opportunities in teaching global health. And through my involvement in the Esther Ireland programme, I've really seen the benefits of well-trained doctors and nurses and physiotherapists working in health partnerships across Africa and beyond. I've also noticed in the past 10 years how there has been huge positive changes in global health education within medical training. And I guess the question of this session is, are we doing enough? Are we focusing enough, for instance, on competencies? We heard Dr. Mike Ryan this morning very clearly. We need to focus more on competencies that can be assessed and recognized rather than qualifications that can be certified. So some of the questions that we're hoping to address during the session include, what are the core competencies in global health? Should global health competencies be incorporated into the core curriculum for all postgraduate specialty programs? And if so, how? Should it be compulsory? Should it be a compulsory part of training? Should it be an elective module? So these are some of the things that we hope to cover in this session. As in previous sessions, please, we encourage you to post your questions, post your comments in the Q&A, and we'll pick them up as we can towards the end of the session. So we have six wonderful speakers today. We have Professor Dermot O'Donovan, Dr. Chris Jenkins, Dr. Niamh McCarthy, Professor Frank Murray, Professor Mark Shrimes, and Dr. Sandra Green. So we're going to hear a very wide range of topics around global health education. So to start us off, without further ado, I'd like to hand over to Dr. Dermot O'Donovan, currently Professor of Global Health at Queen's University, Belfast, and well known to many of us for his passion and his commitment to improving global health education across the island of Ireland. So over to you, Dermot.
Thanks very much, Nadine. I thought I was going to be sharing my own. Okay, I'm not. Okay. And I've changed my slides, so here we go. Thanks very much. I was just reflecting, I was looking at a meeting that happened in Galway in September 2003 about global health education for medical students and nursing students. That led to the Irish Forum for Global Health and a range of other activities. And it's fantastic to see this and how wide this is. So what we're going to do, next slide please, is just see what are we talking about. We've heard lots of different definitions of what global health is and what we're talking about. So can we just see if we've got any commonality here? So can I ask you to go to menti.com on your phone and put in the code 7007484. And Erica, you're going to switch over to Menti, I think, aren't you? Are you going to share it or will I? Okay, great. Okay, so can I just ask you, put in the code 7007484 and just answer this question here. Where are you? Okay. So we have there's a lot of people on the island of Ireland, but there's a lot of people in other places as well. Great. New York, Canada, Lusaka, Kenya, Oxford, Castle. Great. Okay, so this is pretty global straight off. Brilliant. We just go to the next slide, please. So can you just write in a few words, what does global health mean to you, please? Okay, so we've got health of the world, relieving the burden of disease, equity, essential, inclusive, equality, everything, intersections. Yeah, you can scroll it down, please. Equity, access, high standard of health, working together, sharing knowledge, thinking across different settings, safe to travel, competencies, decency, dignity, respect, fairness. Great, great. Solidarity, equity, solidarity, sustainability, biodiversity. Great. Okay, thanks very much. We'll come back to those for a few more questions in a few minutes. Just go back to my slides. I was just going, the next slide, when it comes, is just the probably most used definition of what global health is. Some of you will be familiar with this. It's been around for 10 years or more. Study, research, practice, priority in improving health and achieving health equity for people worldwide. So we've had a lot of you are thinking in those sorts of ways. Can you go on, please? Okay, so if you can just flick through these, because there's a multiplicity of different, there's a whole growing literature about what global health education includes and what global health curriculum is for undergraduates and postgraduates in medicine, in other healthcare professions, and more widely. It's not just for health professions. And next slide, please. And this is all in the context. We've heard several references to the Sustainable Development Goals already. So SDG 3 about health and well-being is interconnected into all of these. And we need to bear that in mind in terms of determinants of health. Next slide, please. So do you need to go somewhere to be involved in global health? Do you need to fly? Well, we're showing today you don't. And increasingly from the discussions we've been having about education between and within countries, that when there is connectivity, you probably don't. Next slide, please. I would have talked about this before. Some people have heard me talk about the Lancet Commission on the Education of Health Professionals for the 21st Century, published about a decade ago, talks about education to strengthen health systems everywhere and stresses again our interdependence and talks about the roles of different competencies. Next slide, please. In Britain, 3 years ago, the Academy of Medical Royal Colleges did a big, wide consultation and came up with these capabilities that they recommended that all medical graduates in the UK should graduate with these sorts of areas of capability. So you see it's diversity, human rights and ethics, it's determinants, it's global epidemiology, global health governance, and aspects of health systems and health professions globally. Next slide, please. And the General Medical Council that sets the guidance for medical education in Britain has a new guidance as to what should be in medical education. And in their outcomes for graduates that all medical schools in Britain now have to adhere to and are assessed against, includes among these different competencies and outcomes is that people are able to outline the principles underlying the development of health, health service policy, clinical guidelines, health economics, equity, and sustainable healthcare are in there. You see evaluating the determinants of health. Again, a global perspective is in there. And the bottom one, the role of ecological, environmental, and occupational hazards, mitigating these effects. And again, there's a global dimension to that. Next slide, please. I work in Queen's. Next, please. So we have a new undergraduate medical curriculum that's just started this year. It's case-based learning. So every 2 weeks, students are exposed to a new story. So we're into the 4th or 5th week of it already. So they came in, they had somebody in a road traffic accident that raised issues of first aid and ethics. The second one was pregnancy. So they're doing things around the embryology and development, but they're also doing things around how mothers are looked after and about prenatal care. The next one will be about immunization. So, there'll be multiple different things. So this GCAT theme that is the DNA of this is going to run through the 5 years. They'll change every 2 weeks to a different case. And in every case, they have to have these sorts of elements. So the threads that are going through in all the way through in the global theme include the public health, but also cultural competence, equality, diversity, the interface between different care settings, the wider determinants of health, social accountability, sustainability, all under the heading of global health. So next slide, please. This is the slide item after changing. In the meantime, I'm after putting a slide from, I used to work in Galway before, and we had global health in the undergraduate curriculum in Galway. And Maeve Winnon is an obstetrician in Castlebar, who I hope is here today. And I've been running a course in ACL for the last 10 years or more, where we bring students for as part of a special study module on healthcare in low resource settings. It's primarily looking at low resource settings in the global south or poor parts of the world, but we deliberately go to a place with limited resources where we get the healthcare providers there to talk to us about appropriate technology and everything in ACL. That has been expanded. When I was asked by Kevin Connolly, who's a pediatrician in Ballinasloe, asked if he could come on the course. And that led to us developing that course with the HSE and with the Irish Global Health Network, so that now we weren't able to run it this year, but we have up to 50 people coming across different health professions, not just postgraduate medical trainees, talking about global health and aspects of humanitarian emergencies and other ways of working in low resource settings. But that prompts this discussion about partnership and where partnerships are with Jonathan's already referred to the fact that healthcare workers and skilled healthcare workers tend to be in cities. A lot of global partnerships or north-south partnerships tend to not cover a lot of remote rural areas and other issues that raises. Next point, next slide.
Diarmuid, just 2 minutes left. Thank you.
Okay, and in terms of these partnerships, we need to talk much more about reciprocity. Go on, this is where I need to have control rather than aid. That this is, you talked about student or doctors coming on exchanges, and I think opportunities to go to other places. That traffic has been mostly one way so far, and we need to address that in other ways. Next slide, please. And we also need to address the wider commercial and political determinants of health. Next slide, please, for the global syndemics. We need to talk about rights. Next slide, please. And we need to talk about universal health coverage and all the different dimensions of that. Next slide, please. This is from the European Patient Forum, that universal health coverage includes rights, discrimination, access, affordability, and sustainability in healthcare. Next slide, please. And we're going to hear more about planetary health, which has to be considered. And next slide, please. And the NHS has recently announced that it's going for a net zero NHS. Is this something we need to be advocating in terms of global health in Ireland and in other countries? Next slide, please. And we need evidence to inform all of this. There's a lot of things happening. There's a lot of practice and a lot of policy. Next slide, please. We need to be clear about how we're doing this. We need to have knowledge that makes absolute sense and have evidence-informed practice in global health education. Thank you. So over to Chris. The overarching theme of the SDGs must be what underpins what we're talking about in terms of global health as well. Thank you.
Diarmuid, thank you. Thank you very much. And we look forward to coming back to you with some of the questions. And again, reminding people, please put your questions and your comments into the Q&A. We really want to hear what you think. Handing over now to Dr. Chris Jenkins, who's a researcher in the Centre for Public Health at Queen's University, Belfast. Over to you, Chris.
Thanks very much, Nadine and Diarmuid. And thanks for the opportunity to speak at this conference as well. I'm only going to speak for a couple minutes and really just to piggyback on what Diarmuid has already introduced. And what I want to talk about is a survey that we've been developing at Queen's University, which Professor O'Donovan has been leading, to give you a little bit of background on that survey and to ask for support of different people within this conference to help us disseminate it. So one voice that has potentially been missing from the conference so far is that of students themselves. And what we would love to do in terms of building the evidence base that Professor O'Donovan was talking about is try to understand what students think about the global health education that they're currently getting. So this is medical undergraduate students in the UK and Ireland. What do they think about the global health education that they're already getting? What experiences in global health do they have? What experiences in global health would they like to have through their course? And what would they like the curriculum to look like? So there hasn't really been a lot of research done on this. There's been different surveys that have been done in Germany and a couple of Scandinavian countries. There's a survey done at Johns Hopkins. There's been a small study done in Canada, a couple of small qualitative studies. but no real large scale surveys that try to assess these questions. So we have designed a survey that we want to disseminate across institutions in both the UK and Ireland to try and assess these questions. What type of global health teaching do medical students receive in their undergraduate? What do they think is necessary and important? What concepts would they like to see? What competencies would they like to see built in to their education? How should it be taught? Questions like that. So we have designed this survey, ethical approval from Queen's University and from the University in Galway. And one of the things that we wanted to do maybe in this very short talk is just share one or two of the questions with this conference. And obviously the people involved in this conference are probably not representative of who the survey will go to, but at the same time it would be interesting to compare what people in this conference think about a couple of these questions. So if you could go back to Imgti using the same code 7007484. And I think you can select 3 of these different issues. So these are obviously just very broad concepts and issues in global health. But if you were to say what the top 3 priorities are for global health education of undergraduate medical students in the UK and Ireland, what would you answer? So quite a lot of people responding to non-clinical determinants of health, things like social, political, economic, commercial determinants, climate, planetary health also scoring very highly. Interesting clinical practice in lower income contexts, not really scoring highly. So, are we moving beyond that idea that global health is just clinical practice in lower middle income contexts, something a little bit more holistic? Climate change still growing. So we'll give maybe another 10 or 15 seconds and then we'll move on to the next one. I think it's interesting, even just looking at these results, perhaps something for people to reflect on it, the determinants of health and climate change and planetary health. Is that what global health curriculums currently look like for medical undergraduate students? Are those concepts and those principles forefront and center of our current curriculum? Do we need to think about how to change it? So if we can move to the next question. And this is just, I just want you to broadly estimate the percentage of students, and I mean this across the UK and Ireland, percentage of medical undergraduates who undertake an international medical elective in an LMIC. So just a broad brush estimate. You might know it. So most people going into the bracket of 20 to 40% of students, some lower than that.
And Chris,
Obviously,
there's a question there for you. Are you concentrating just on medical students? Should other medical professionals not be included?
For the whole survey, for this question, any students that are in any sort of medical education, so pharmacists and stuff as well, absolutely can include in that. And I can address the other question about participants of the survey just after. So most people saying around 20 to 40, which is obviously this number changes every year, and post-COVID, this number is likely to drop off a cliff, but that is normally the bracket of 20 to 40%, which each year take an international medical elective in an LMIC. So that is quite a high number as well whenever we think about that across the UK. And so thank you for doing those couple Mentimeter questions. The reason why I asked that second question on the international medical electives as well is because quite a lot of the survey that we're going to do is also going to address questions related to medical electives. Do students feel as if they are appropriately supported? Do they feel as if they have the right level of training pre-departure to undertake an international medical elective, particularly with a focus on medical electives in lower middle income countries? So our survey will also tackle some of those questions that I know have been a running debate within this field for quite a while. So that's basically just a rapid overview of the survey that we're that sort of the rationale for the survey that we're wanting to do. and really just emphasize that it's important that the voice of students is included within these conversations as key stakeholders. So if anyone has any networks that they feel that they could use to help disseminate this survey, as I say, it's ready to go. We have ethics already for it. I'm going to put my email address and Twitter handle and different things into the chat box. And if anyone feels as if they would be able to help get this disseminated within different networks, that would be fantastic. It's for all medical students across the UK, all undergraduate medical students across the UK and Ireland. So thanks very much.
Thank you, Chris. Thank you for that. And just with the very short time that you have left, Diarmuid, there's a question for you might answer before we move on. In your view, from Dr. Brendan O'Shea, in your view, what are the big obstacles and the quick wins in medical education in global health in Ireland?
The opportunity is that students want it. The opportunity is that students are demanding it. And I guess one of the big challenges is that the curriculum is really packed, and it's finding places for this. Having designed a course that was a global health standalone course, I'm now beginning to think it would be much better if it could be just interwoven in many places, but that's probably much more challenging to do. And maybe having a standalone course on any subject may not be the best way to do it. It should be linked across different areas. So that means building competency and skills and knowledge across a whole range of different people who are teaching.
Thank you, Diarmuid. We're going to move on, and please, again, I love to see the questions coming in, the comments coming in the Q&A. We'll pick them up as we can. I'm going to move over now, hand over to Dr. Niamh McCarthy, who's in her penultimate year in higher specialist training in psychiatry. She's also the co-chair of the subgroup on incorporating global health into postgraduate medical training programs of this forum. So over to you, Niamh. Looking forward to hearing your presentation.
Thanks, Nadine. Just going to share my screen here. Can you see that okay?
We can.
Brilliant. Thanks a million. So I'm absolutely delighted to be here today. It is a privilege to be able to speak at such a wonderful conference. I am no expert in global health. However, I'm extremely interested in the topic and keen to work alongside my colleagues to work towards postgraduate medical training going global while also staying local. So I'm going to begin by answering two of Diarmuid's questions. He asked, where am I at the moment? And what does global health mean to me? For those picture, it is an iconic photograph. It's called the pale blue dot, and it is a picture of the planet Earth taken in 1990, 6 billion kilometers away. The astronaut credited with it, Carl Sagan, spoke about it, and what he said, for me, sums up what global health means. Look at that dot. That's here, that's home. That's us. On it, everyone you love, everyone you know, every human being who ever was, on a mote of dust suspended in a sunbeam. Earth is a very small stage in a vast cosmic area. There is perhaps no better demonstration of the folly of human conceit than this distant image of our tiny world. To me, it underscores our responsibility to deal more kindly with one another and to preserve and cherish the pale dot, the only home we've ever known. So, if we were to take that on board, it really is a small world after all. And here on this little dot, we as healthcare professionals have taken on the responsibility of providing healthcare. Human health entirely depends on how we treat each other, other species and organisms, and the planet that we all share. We are all interconnected and interdependent. Global health does not mean public health somewhere else. And we know this because COVID has underlined that things that happen far away impact us all. And this slide underlines a few things. The connection between public health and planetary health, the destruction of forests, biodiversity loss, and also how increasingly we look to doctors and other healthcare professionals for leadership. So I want to focus just a little bit on Ireland. I want to look local and at the natural world. So here in Ireland, 91% of Ireland's important habitats are struggling. And this is because of huge amount of agricultural land use. As a consequence of habitat loss, this leads to species loss, and 20% of Irish species are at risk of extinction. This includes animal life as well as plant life. And 43% of bees are at risk of extinction. And those photos at the bottom of the page there have relevance. That little fellow down in the bottom left, that's the curlew. And they've declined by 96% since 1970. The flowers on the right-hand side, the spring gentian, that's in the burn, which is a very special habitat. But in positive news, the burn is a very protected area, and this has been very helpful. But what does any of this matter to us doctors? We'll hear from Dr. Sandra Green a little bit later about the importance of our health in relation to our carbon footprint, and agriculture has a huge part to play in this. Indeed, antibiotic resistance, this is linked to the huge amount of antibiotics that are given to animals in agricultural work. And with the loss of species, we're losing our genetic library. And a lot of our plant life and animal life have helped us to develop the treatments that we have. And this risks future treatments. So you'll see down below there, the foxglove, which is native to Ireland, was used to develop digoxin, and meadowsweet down there on the right-hand side, that's been used for aspirin. If we lose our bees, we're losing pollinators, and this has an effect on food security. And what about Ireland's global community? 11.6% of our population are non-Irish nationals. So we need to be aware of this in terms of the patients that we're treating. Our medical workforce, we have the highest reliance on foreign trained doctors in the EU at 39%. We need to be familiar with this in relation to the global shortage of doctors. We also need to be aware of this in terms of how we interact and treat our colleagues. And Ireland has a place on the international arena, as we've already seen this morning from Dr. Mike Ryan. So as a psychiatrist, I'm going to use psychiatry as a specialty to demonstrate how these things all come together. So we know that there's an association between green spaces and benefit to health. We also know that there's a lack of equity in relation to access to green spaces. We also know that there's an association between pro-environmental behaviour and access to neighbourhood nature. And that perpetuates a cycle in terms of destruction of our environment. We know that as psychiatrists, we can have an effect on the healthcare of our planet. Psychotropic medication levels are detectable in the water, and this can have effects for aquatic life. Migration is linked with higher levels of mental health. Some papers would say that up to 60% higher rates of psychosis are in migrants. As a psychiatrist, I have to be aware of the culture of the patients I'm speaking to, because there are certain mental health conditions that present in different ways, culture-bound syndromes. How we support our colleagues and build our workforce has already been spoken about. And the key message that has been mentioned today already, to not forget those in marginalised and vulnerable groups. And arguably mental health is one of the least resourced areas in health. And in fact, part of the budget in Ireland is only 6%, and it should be double this if we were to catch up with our EU colleagues. So in relation to education, I'm going to steal a phrase that Mike Ryan used this morning. He spoke of strengthening learning ecosystems. And indeed, if we look at the SDGs, education is a multiplier. And education systems and health systems are inextricably linked. So the WHO has stated that we want to develop health professionals who are globally competent and locally relevant. The Lancet spoke about a mismatch between present professional competencies and the requirements of an increasingly interdependent world. In the UK, the General Medical Council, in relation to their professional requirements, have stated that basic principles of global health, as well as global and multicultural aspects of delivering evidence-based sustainable healthcare, is essential. No such guidance exists in Ireland, and there is no framework of global health competencies in Ireland either. Diarmuid already spoke about the differing opinions on competencies, and these are just some examples of the frameworks that exist elsewhere. Myself and David Weeklam have been involved in establishing and chairing a subgroup on incorporating global health education into postgraduate training bodies.
Maybe just 2 minutes left.
We have two objectives. The first is greater integration of global health competencies in postgraduate training curricula, and then also the expansion of overseas training placements. In relation to the first one, we have developed a roadmap that involves a consultation process, the development of a framework of core competencies, and ultimately, we plan to develop a global health e-learning module. I'm very pleased to announce that just as of yesterday, we received great news that the NDTP, together with support from the College of Anaesthetists and of course the Forum, have granted us development funding to proceed with our plan. There's a lot of dark things happening at the moment, but in a dark time, the eye begins to see. This project is a beacon of hope for the future. It sends an empowering message to doctors that we can bring hope and efficacy. It's clear that we have an important role in the health and well-being of all people on the planet. The RCPI showed that 90% of doctors want to take a leadership role in the area of sustainable healthcare. This is an opportunity for them to do so. And the final thing I'm going to do is just ask for a little bit of help with our project and put a question to the audience with Mentimeter. And I'm going to just ask Erica to help me with that. Erica, would you be okay to share the Mentimeter questions? So again, like earlier on, we would ask you to go on to mentimeter.com on your telephone and put in the code 7007484. And we're asking the question, what are the core competencies in global health across the continuum of training for doctors in Ireland? And be very grateful for if as many of you as possible could fill this in, because we're going to use this as a part of our consultation. So we've got some interesting ones coming in, and people have such varied understanding global health means: kindness, equity, inclusivity, planetary health, person-centeredness, language, humility and understanding, awareness, empathy, equity. These are all words that I feel very proud to be associated with here today at this symposium. Communication skills, open-mindedness, compassion, humility. How to train those without the same resources as ourselves. So these are all really helpful comments to have, and this will help us to develop our plan going forward with postgraduate training. And there might be some questions later on that we can discuss further. Thank you very much.
Thank you, Niamh. Thank you for that last slide on core competencies and the opportunity for everybody to input, and also for the attention on mental health and well-being. That's a theme that's coming up since the first session this morning. So wonderful. Wonderful. I'm going to move along now to our next speaker, who is known to many, Professor Frank Murray. He's the director of the National Doctors Training and Planning Programme with the HSE, and he's the immediate past president of the Royal College of Physicians in Ireland. Over to you, Professor.
Hi, how are you? Can I get my slides up? Thanks very much indeed, Nadine, for introducing me. Do you have my slides there?
They should be coming any minute.
Thanks very much. Well, first of all, thank you very much for inviting me from NDTP. And thank you, Niamh, for recognizing what happened yesterday, which is that we found some funding to support global health education postgraduate trainees. And that's I think you've seen that there's a commitment throughout the HSE to do that, and personally, I'm very devoted to it. And I'd also like to recognise David Weekliam and Diarmuid Donovan, with whom I've been collaborating over time, who've made fantastic contributions to global health, and I wish them well and thanks very much. The topic I'm going to talk about today really is an initiative here in Ireland called the Imgti initiative, and it's there we are. Yeah, and you know it's a bit of the opposite of what's been discussed a lot here. It's a little bit about taking doctors from low and middle income countries in partnership to train here and then to return to their own countries. And it was mentioned earlier on, in fact, from Zambia, talking about getting out of country experiences. So that's really what we have an initiative around that. And I'm going to explain it today and explain why I think it's particularly important that we do it here in Ireland, because we've got such a terrible situation in relation to medical workforce, which I'm going to outline to you. So if you could have the next slide, please. So there are real medical staffing challenges here in Ireland, and I'm going to outline a couple of them on the next couple of slides, if I can, just to show you how unbalanced our medical workforce is and why we need to take initiatives like the IMGTI, which is the initiative I'm going to talk about, and that stands for International Medical Graduate Training Initiative. So we can go on to the next slide, please. Ireland's got a funny situation, and this has been highlighted recently. We've got very few hospital beds. You can see where we are. We're way down the league, well below average in the OECD league of hospital beds per 1,000. So A, we've got very few beds. B, on the next slide, please. We have a very high occupancy rate, which is what you'd expect. And there are things that we don't really want to have. Now, combined with those structural deficits we have, if you could look at the next slide, please, you'll see that we produce the highest number of medical graduates per 100,000 in the OECD and EU. But despite that, next slide, please, we actually have well below the European average of doctors practicing in Ireland. So we have all these, we haven't enough capacity in beds, we've got massive overproduction of doctors, and yet we don't have enough doctors in Ireland. Such is the rate of emigration in Ireland currently of medical graduates. Next slide, please. Now, in addition, we have had a gap in our hospitals to staff our hospitals, and we've got a unique situation here where we've got large numbers of non-NCHDs, that's junior doctors, non-consultant doctors. I don't like the term junior, but that's the term that's commonly used. And we have in Ireland here a completely unbalanced workforce from a point of view of non-training scheme doctors, of NCHDs. And the next slide would show that when we look at non-training NCHDs, the number of those doctors is outlined on the top bar of this chart here, and you'll see that their number has increased exponentially in the last 4 or 5 years. So what's happened is we've imported a lot of doctors to Ireland to work in non-training programs, which really isn't fair to them, I think. Next slide, please. And then when we look at the total number of junior doctors, so-called, or NCHDs in Ireland, they divide roughly 50-50 into trainees and non-trainees. Now that's a very undesirable situation, and it's the highest number of non-trainees working in the workforce as junior doctors that I've been able to identify in the Western world. Next slide, please. Now, where are these doctors? They're spread across nearly all of the specialties. This is a distribution of trainees in grey and non-trainees in green across the specialties. So it's right across the specialties, particularly high in surgery and relatively low in radiology and pathology. Next slide, please. And then when we look at where they are, as you'd expect, this is a graph, an image showing where the doctors are. Green is mainly training doctors, and red and orange and yellow are non-training doctors. It's a spectral distribution. And what this shows is that the big cities, Dublin, Cork, and Galway, have plenty of training scheme doctors, and the non-training scheme doctors are mainly in the smaller hospitals and in the non-metropolitan hospitals. Next slide, please. So, and finally, in relation to what the problems we have here in terms of having a very unbalanced workforce, if you look at the number of foreign trained doctors in European countries, the highest number at 39% is found in Ireland. So, and this, of course, goes against the WHO Global Code of Practice, and I think it's a very undesirable situation to be in. And the solution to this, I think, is complex and tricky. But I'm going to show you one initiative that we've undertaken. Next slide, please. So this is the HSE Imgti scholarship program, and this is a partnership. The word partnership's been used quite a lot here today, quite appropriately. And this is a collaboration that's been established with Sudan and Pakistan. And it involves the NDTP, that's the organization that I'm involved in, which is involved in helping coordinate training here in Ireland, the Medical Council, the training bodies or Royal Colleges, and the hospitals or psychiatry services in the community. And what happens is that doctors come to Ireland from Sudan and Pakistan for a 2-year training program, and then generally at kind of a senior SHO junior registrar level, and then they're obliged to return to their home country, rather like having a J1 visa going to the USA. And I think this benefits a number of, it benefits the trainees, the WHO code of practice. It's programmatic, so it's not ad hoc. The hospitals in Ireland definitely gain because they get better trained staff, there are less risks, and I think it's good for all parties. Next slide, please.
2 minutes left, Frank.
Okay. This shows that the numbers have increased and the programs have increased. And so far we've had 350 participants through this scheme to date. Next slide, please. And it's been, next slide, yeah, that's just showing how we've had MOUs with the countries participating. Next slide, if I may, please. So this is how it's organized. It's organized through the training bodies in Pakistan and Sudan. They apply, the trainees from their program apply there. They are shortlisted by a training body here. They're interviewed by Skype. Those who are selected then come here. They undergo an induction, etc., etc. They've got a point of contact with the training bodies. They're fully paid an NCHD salary here, so they're looked after well, and they actually get some financial support in addition. Next slide, please. I won't go into the detail, but the feedback from the colleges and training bodies in Sudan and Pakistan and from the trainees has been almost uniformly positive. It's also almost uniformly positive from our partners here in Ireland, the hospitals and training sites. Next slide, please. So just to say the evaluation has been very positive. Because of time, I'll skip this if I may, please. So the keys to this program are collaboration, the fact that they're jointly certified between, the trainees are jointly certified between here and their home country. It's well organized here. The training bodies and NDTP have made substantial contributions to that. There's involvement of regulators, benefits to all of the stakeholders, and the program it gets better, I think, a little bit every year. Next slide, please. So to summarize, IMGTI provides training opportunities to trainees from Sudan and Pakistan. It facilitates their recruitment from their home country and their return, more importantly, to their home country. So there's no brain drain involved in this. It provides structured training. There's an obligatory return to prevent brain drain. Huge benefits to Irish hospitals and the HSEs. It has the effect of reducing our dependence on non-training scheme doctors, which I think is the correct direction of travel, and it benefits all involved. And I think my next slide is the final slide. Yeah, just to say, I think there are opportunities to, for this program, I think we could extend it to more than 2 years, for instance. I think we could develop fellowships for more senior trainees who want to be more specialized. And I think we could increase the numbers substantially. And I think this does offer us opportunities of genuine partnership, out of country experiences for trainees, for doctors from other countries, but without the likelihood of them staying here. And I'd like to thank all our partners who've been involved with us in this regard. Thanks very much indeed, Nadine, and the rest who are on the Zoom call. Thank you.
Thank you, Frank. Thank you so much. That was really interesting to really hear that program from the beginning to where you are now, and just encouraging everybody who would like to ask more questions about it or has any comments or suggestions to please put them in the Q&A, and we will circle back around. Wonderful. Okay, moving along, we're going to move to Professor Mark Shrimes. He's a professor of global surgery at RCSI, and he has a particular interest and experience in surgical delivery in low and middle income countries. So over to you, Mark.
Thank you very much. I'm going to see if I can't share my screen. Excuse me.
Mark, not sure if you intended to have your video on or off, but we can.
Oh, I do intend to have it on. Is it off?
It's off at the moment, yeah.
Sorry about that. Is it on now?
Perfect. We can see you.
Great.
With a nice backdrop somewhere in New York, it looks like, oh no, look, it's RCSI.
No, this is just it's a fake backdrop at RCSI.
Great.
But no, thank you for the opportunity, all of you, to be here. It's been really fascinating to listen to sort of the themes that are emerging and those Menti questions that people have been asking and the answers that people have been giving. I'm just gonna spoiler alert you here that you're gonna see some of the same things in the presentation that I'm gonna give as well. So I'm the new chair of global surgery at a new institute of global surgery at RCSI. And I've been asked to speak about what global surgery education is. What should everybody know about global surgery education? Which is a big topic for 10 minutes. So I'm gonna narrow this question down to a sort of more concrete question, which is, what are the differences in the competencies between education in surgery and education in global surgery? RCSI, for example, has a Department of Surgical Affairs and also has an Institute of Global Surgery. What is the difference between these two? What do the Venn diagrams look like? Where do they intersect? Where do they not intersect? What do the competencies of these two look like? I have nothing to disclose. I get some funding from the Iris O'Brien Foundation, but they don't have anything to do with what I'm speaking about today. So as I like to do with a lot of my talks, I want to root this talk in the story of patients. And a disclaimer here that some of the pictures that I'm going to show you are a little bit hard to look at. And those of you who've heard me speak before have definitely met this first patient because I talk about him all the time. But the first patient is a patient of one of my colleagues from Madagascar. His name is Sombane, and he's a rice farmer from the southern part of Madagascar. And he has had this tumor growing off the left side of his face for the last 30 years. The second patient is a patient of mine, also from Madagascar. Her name is Patricia, and she has had this tumor growing off the right side of her face for the last 20 years. Now, as we talk about this question of what are the differences in competencies, what is the difference between education in surgery versus in global surgery, I'd really like to talk about these pictures and how we look at these pictures. Because as a surgeon, I was trained to look at these pictures in a particular way. I was trained to ask questions like, what are these tumors made of? And I'll tell you, Patricia's tumor is a pleomorphic adenoma. It is the most common tumor of the parotid gland anywhere in the world, Madagascar or Ireland. Whereas Sombane's tumor is a little bit more rare. It's a low-grade basophilic carcinoma. So I was trained to ask that question. I was trained to notice, for example, that Patricia's face is symmetric, but Sombane's is not, which implies that the marginal mandibular branch of his facial nerve is already involved in the tumor. I was trained to think about the vasculature underneath, and do we have to deal with the vasculature as we take these tumors out? So as surgeons, we tend to look at these pictures and ask a couple of questions. We ask, what is this tumor made of, and how? How do we take these tumors out while keeping the patient's facial integrity intact? I want to propose that a trainee in global surgery should come out from global surgery training asking a different question of these pictures. That trainee should ask why. Why do these tumors get so big when they are made of exactly the same stuff as tumors that I would see in a practice here in the US or in Ireland? And to start to get at the answer to that question, let me actually tell you the story behind Sombane's tumor. Because in the 30 years that he'd had his tumor, it's not like he didn't know there was a tumor growing off the side of his face. I mean, it blocked his vision. He knew it was there. He'd been to 10 different hospitals, spending a lot of money to try to get this tumor treated. Only 3 of those hospitals were surgically capable. Only 3 of them had surgeons in them. None of them would offer him a procedure. He finally had his procedure with my colleague at a charitable surgical organization that we work with on the east coast of Madagascar. He's a rice farmer from the south. So to make the trip from the south to the east meant they had to be carried on someone's back for 2 days just to get to the nearest road. And then it was a 6-hour trip up the road to get to the hospital. And this charitable surgical organization, like most charitable surgical organizations and like a few district hospitals in resource-constrained settings, provide surgery for free. Surgery, the postoperative care, the medications, all at no cost to Sombane. And yet, to pay for that 2.5-day trip from the south to the east, this rice farmer had to sell his rice farm. So he faced a catastrophic financial event in search of his surgical care. And as you start to listen to Sombane's story, you start to hear the outlines of a deeper underlying systematic disease whose symptom is a tumor as big as Sombane's. And Sombane's not alone. We know, for example, that 30% of the world's disease burden requires surgery at some point in its disease course. But at the same time, 5 billion people around the world don't have access to surgery. We know that 81 million people, 16 times the population of Ireland, are pushed into poverty every year, like Sombane was, by the costs of getting their care, their surgical care. We know if we ask people who don't have access to surgery, they'll talk to you about the same things that Sombane talked about. They'll talk to you about an inability to afford care, a lack of surgeon availability, a fear about quality and safety. They'll talk to you about the fact that there aren't enough procedures being done in their country, and they'd be right. Of the 313 million operations that happen around the world every year, only 6% happen in low-income countries. So as we start to think about the competencies that a global surgery trainee we would want them to come out of their training with, we can start to see that in Sombane's story, into what goes into and what comes out of Sombane surgery. What are the barriers that Sombane has to overcome? And barriers that we can split up into demand side or patient side barriers and supply side or system side barriers. On the demand side, things we've talked about: cost, distance, transportation, a lack of knowledge that surgery exists to treat the problem that ails you. On the supply side, barriers of lack of providers, of infrastructure, of quality, and there are governance issues in surgery. In many countries, surgery doesn't even appear in the National Health Plan. Surgery is done over there in the corner. It's the thing that the health system will deal with once we've dealt with infectious disease, once we've dealt with nutrition. But when you start overcoming these barriers, when you start providing surgery to somebody, you get outcomes that I've also sort of split into this demand and supply side. On the demand side, on the patient side, you have outcomes that I would have been trained to think about as a surgeon. Did the surgery happen? Did the patient survive? Was the tumor removed? Were there complications? Did he have a surgical site infection? But there are sort of these second level outcomes that we don't necessarily think about as surgeons that somebody cares about. Like, did I have to sell my rice farm? Could I return to work after my surgery? Was there shame and social isolation before my surgery, and do I have it afterwards? Overcoming the supply side barriers gives us an increase in the number of surgeries and providers in hospitals, and national surgical planning helps overcome the governance barriers. So you're starting to—
Just 2 minutes.
Perfect. You're starting to see a bit of a more holistic view to a surgical system. And this is why when the Lancet Commission on Global Surgery came out with its indicators to measure a surgical system, only one of those indicators was what surgeons would inherently think about, which is perioperative mortality. The other 5 were addressing this deeper underlying systematic disease. So as we start to think about where this Venn diagram is, there are competencies that exist in both surgery and in global surgery. As a surgeon, I learned about anatomy and suturing and the care of the post-operative patient and the intensive care patient, and all the specialties on the left. But the global surgery trainee would need to learn about implementation science, economics and ethics and human behavior, how that influences how people seek care, qualitative and quantitative research, advocacy, policy writing, and modeling. Should the global surgery trainee know about anatomy and what happens in the operating room? Absolutely. And should we be training surgeons about this deeper underlying systematic disease? Absolutely. But we need surgeons to do surgery. We need surgeons to take Patricia and Sombane from here to here. And we hope that the global surgery trainees would start treating that deeper underlying systematic disease so that the next Patricia and Sombane's tumors aren't as big as these. Thank you very much.
Thank you, Mark. Thank you so much. Thank you for sharing the story of Sombane and Patricia. It made your presentation very powerful, and just that question of why very much has stayed with me, and I'm sure everybody listening. So again, questions, comments, please put them in the chat for Mark and we'll come back to them. Moving to our final speaker of the day, and a wonderful topic to have the final word. Dr. Sandra Green is a respiratory registrar. She's inspired originally by the Australian Doctors for the Environment. She recruited a handful of like-minded doctors, and together they founded the Irish Doctors for the Environment. And I'm sure you can join me in saying that we're seeing the Irish Doctors for the Environment everywhere in all of our conferences and meetings, and wonderful that you're putting planetary health and the environment smack bang on the agenda. So over to you, Sandra.
Thank you very much, and thank you for the wonderful opportunity to speak at this symposium today. I'm absolutely delighted. And thank you to all the very insightful speakers that have gone ahead. It's very tough acts to follow. I'm going to speak to you today about why Irish Doctors the Environment was formed and what we've been doing to communicate the science. Next slide, please. So this image is called Earthrise, and it's an iconic image from the Apollo 8 mission, and it's come to symbolize the environmental movement, and particularly the world's first Earth Day in 1970. It represents the world's isolation, its beauty, its fragility, and its inherently unique ability to sustain life. Next slide, please. And sustain life it has been, and there's all 7.7 billion of us on the planet now. Since that picture was taken, the population's doubled. And all of this 7.7 billion at the most very basic needs need clean air, clean water, nutrition, and shelter. Next slide. Sorry, next slide. Thanks. Unfortunately, for some of the other species, they haven't been able to meet these basic needs. And we're now seeing a situation where up to 1 million species are facing extinction. Next, please. And as Niamh touched on, our pollinator species are so low in some places, particularly in, for example, in this picture in China, where they're hand pollinating apple trees. Next. And up to 90% of our children are breathing polluted air every single day. Next. And even in Ireland, we're not exempt. And we're seeing increasing breaches of what the EU has said is an unsafe level of nitrogen dioxide in our city of Dublin. Next. And since this picture was taken, we've seen an exponential increase in the number in fuel consumption across the board. Next. And with that, we're seeing, next, an increase in global warming. We need to keep temperature rise from pre-industrial levels to below 2 degrees in order to continue society as we know it. But where we're headed at the minute, we're headed for closer to 4 or 5 degrees. Next. Climate change impacts on every aspect of our health, and it works in systems and cycles. And it's often force multipliers for the many important global health issues that have been raised today. Next. Some good news though. The Earth Overshoot Day is the day every year when we have used up all of the resources that the Earth can produce in 1 year. And since the recession in 2008, this date has been becoming sooner and sooner each year. But this year in 2020, thanks to the restrictions in place for COVID-19, this day actually was extended to mid-August. Next. Not every country contributes equally. And in Ireland in 2020, our Earth Overshoot Day was in 26th of April. Next. The Lancet Commission have warned us that the continued degradation of the Earth's ecosystems threatens the global health gains that have been made over the last century. And in short, that we are mortgaging the health of future generations to achieve economic gains in the present. Next. I want you to think back to early 2020 when we saw those devastating images of wildfires savaging through Australia. Next. And you can see here on January 3rd, the extent of the fires, which burned up to 20% of Australia's fires. We thought that this might be the defining moment of 2020, but on that very day, the US received the first notification of a new novel virus in China. Next. And it wasn't long before coronavirus took over the media. And we've been hearing all about it's been taking over ever since, really. But we had to watch at this time as our window to contain this virus and our window to prevent a pandemic closed. And subsequently, we've seen massive changes in our society. Next. We are standing at a very similar window now for climate change. We have a very short window to act, but we do have a chance, if we act now, to alter the course. And we know that climate change will affect the very same vulnerable populations that we've seen in COVID, which is our elderly. Next. Those with chronic diseases. Next. Our poor and our disadvantaged. Next. And our homeless. And our refugees. Next. We have currently 70 million refugees in the world, and we struggle to meet their basic needs and their health needs. Next. But it's estimated that by 2050, there will be 200 million people displaced by climate change. Next. If we don't tackle climate change, conditions will become unlivable for significant proportions of the world's population. Next. So how have we been contributing in Ireland? Next. Well, we've been contributing quite a lot. And when we needed to reduce our fuel consumption, we've actually been increasing it year on year. Next. But we have shown ourselves that we can be leaders. And we were the second country in 2019 to declare a climate emergency. Next. But when our EU report card came out in 2020, we were 26 out of 28 towards achieving our European package. Next. But then again, this year, Friends of the Irish Environment took the Irish government to court as they felt that their measures in place to reduce greenhouse gases were inadequate. In this landmark case in the Supreme Court, a historic ruling was made. And as a direct result of this, we have our new climate law was published. And this brought into law our 2050 climate targets. And it set out carbon budgets and included provision for setting sectoral targets. Next. We at Irish Doctors for the Environment will be watching very closely to ensure that healthcare is included in the sectors that receive a carbon target. We know that healthcare contributes 4.4% of emissions globally, but not in Ireland where we're not recording them. Next. And as has been mentioned before, we have a lot of work to do before we can start talking about a net zero HSE. Next. But we do have solutions, and the Intergovernmental Panel on Climate Change have clearly laid out exactly what we need to do. So in order to keep temperature below 2 degrees, we need a complete decarbonisation of power away from fossil fuels. We need a reorientation towards sustainable global food. We need to rethink the structure and the function of our cities. And we need to safeguard other planetary boundaries like deforestation and land use. And we're going to need profound changes in the methods and the delivery of healthcare. Next. And now we have a better understanding about how we need to do it. And we need to do it through collective action, through we, not me. Some of the measures we're going to have to take will be difficult, and they'll challenge others, some more than others. But we know that we need to do this in order to safeguard the health of everybody. Next. We need the political will, and we need to communicate the science. As doctors, we are uniquely positioned and uniquely valuable to the environmental movement because we have experience in understanding the science, communicating it in a way that can affect behavior change. Next. Climate change is the biggest global health threat of the 21st century, and responding to this threat and ensuring that this response delivers on health benefits available is the responsibility of the health profession. Indeed, such a transformation will not be possible without it. We at Irish Doctors, this is how Irish Doctors the Environment is formed, out of the understanding of this. Next. And since it's been formed in 2018, it's rapidly grown. We now have 200 members, a mailing list of 670, 12 committee positions, 14 working groups, and 17 specialties on our consultant board. And I think this rapid growth just really shows that clinicians in Ireland have an appetite for change, and we really recognise the importance of global health. Next.
2 minutes left. Thanks, Sandra.
So we communicate the science through our various campaigns. Next. And we create awareness by publishing articles in mainstream media, but also in medical journals and medical media. Next. And we engage with the education stream. So we work with medical conferences to run green events. And we're working towards trying to get climate change incorporated in all medical syllabuses throughout the island of Ireland. And more recently, we've had the opportunity to work with the subgroup for the implementation of the Global Health e-learning module. Next. And we've tried to implement action by making submissions to the public consultations. And we've done so on sustainable mobility, on a waste action plan, and the climate adaptation plan. Next. And because we recognise that we work best in partnerships, we have joined with international organisations like Healthcare Without Harm, but we also work with national organisations with vested interests. And we do this through the newly formed Irish Climate and Health Alliance. Next. And more recently, to recognise the work of our healthcare heroes, we've raised €3,000 to honour their contribution. And this is enough to plant 1,000 native trees in Ireland with the Home Tree Foundation. Next. Irish Doctors the Environment was born out of a perceived need and a desperation at our current situation, but it has grown to be so much more. All members of the multidisciplinary team, it's a tribe for diverse thinkers and a breeding ground for innovation and action. We believe health, and we've seen it this year best of all, about health is the greatest motivator for why we need to change. But the exact what and how will require everybody, from politicians to mothers, lawyers, children, farmers, retail, absolutely everybody is needed. We do have solutions, but our window to act is closing. If we deliver, we stand to enhance the quality of life and the delivery of improved healthcare to all, while respecting the Earth's natural systems. To do this, though, we will need informed clinicians. And for Irish Doctors to the Environment, the potential for all doctors in Ireland to be competent in global health is one of the most encouraging signs yet. Thank you very much, and please do get in touch.
Thank you, Sandra. Wonderful presentation, and thank you for the email address. You might also pop it into the chat, so if people are interested, your website, they can go and join. Great, I'd love to invite all the panelists just to turn back on their videos and we might just have a short discussion. There's been some questions are coming in, some have been answered. Might start by a question we had there, Diarmuid. It was in relation to your presentation, but I think it's very relevant also to you, Sandra. You know, just recognizing that the global health curriculum is packed, you know, particularly the undergraduate courses, and how moving forward, you know, specifically, do you suggest that we create an action-based education which prioritizes activism and groundwork that supports campaigns addressing issues such as planetary health and economic deprivation? So I might start with you, Diarmuid, and then go over to you, Sandra.
Well, I guess there should be space. Advocacy is supposed to be one of the roles of a doctor. So I mean, there is space. You know, there's a requirement. It is supposed to be part of the role. It's how to create the space to make it, you know, something that's real and that people are doing all the time, rather than having one session over 5 or 6 years that's optional or something like that. You know, so it needs to be some way of. It's about the sort of big change and making everybody realize that you can change things.
Thank you, Diarmuid. And from your perspective, Sandra, how, you know, practically you're looking at this curricula, you've got the campaigning, the activism, the numbers. How are you proposing that this gets into the curriculum?
Yeah, and that's something we've talked about quite a bit. I think there actually isn't space to leave it out anymore. But you know, I think maybe if you're talking about case-based presentations, like there is no health condition that isn't going to be affected by climate change. So it fits into absolutely everything, and it's relevant to every topic you talk about. I think we'll probably get to the point that it'll be hard to have a lecture nearly on anything without including climate change. So I think it lends itself best to the cases base, but it should be everywhere. Yeah.
Yeah, thank you, Sandra. I see another question there for you, Frank. Just in relation to the program, there's small numbers, 2 countries involved in the International Medical Training Program, and it makes it seem like it's a small program to have a substantial effect. When can we see a broader range of options for non-EU doctors to receive equivalent training to EU doctors? You're muted, Frank. Just need to unmute.
Yeah, so it is quite right. It is a small program, but actually you have to start somewhere. I think it's fair to say. And to be honest with you, my vision for workforce in Ireland would be we have a workforce that's staffed by consultants, trainees, and general practitioners, rather like they have in Canada. And we should work towards that. And likewise, as they have in Canada, they've got many trainees come from abroad for a fixed period of training and go back to their home countries, so that there isn't this brain drain that takes place. In terms of just, if you look, I mean, I know I put up a slide there showing that half of the NCHDs in Ireland are trainees and half of them are non-trainees. You know, we simply don't have the capacity or the workforce planning capacity to double the number of trainees here. Like it's all workforce planning would fall apart. We'd really struggle to recruit people in training programs because it would mean nothing, because we'd be training people for nothing at the end of the day. So I think we need to have an integrated plan about how we staff hospitals, and I honestly think we just simply don't have the capacity to make everybody a trainee.
Yeah, thank you, Frank. Wondering, just coming over to yourself, Mark, wondering, you know, one of the key questions for this session was, you know, should global health competencies be incorporated into the core curriculum in all postgraduate specialty training programs? And I guess if so, how? You know, you did a very powerful presentation of why we need it, but how can we do that, for instance, in your specialty?
That's a great question. I think, you know, at the very end, I was saying that it's important for somebody who works in global surgery to know, you know, what happens in the operating room. And I think just equally important for somebody who works as a surgeon to understand the social determinants and the underlying issues that have been discussed today. I'm gonna punt a little bit because I'm not very familiar with the Irish educational system, given that I've only been in Ireland since August. But I agree with Sandra that and she's speaking about the environment, but these issues are not. I don't think we really should compartmentalize them and say, well, there's the environment over here and there's social determinants over here. They are important for everybody to know. So I think we can't not fit them into a curriculum. And in one of the mentee questions was, should it be required? I mean, I think it should be required as part of the core training of every surgeon to understand what's happening behind the diseases. Yeah,
thank you, Mark. And I'd love to hear your perspective on that, Niamh. From you're coming in from a psychologist perspective, and you're muted at the moment.
Hi, thanks. Yeah, I would agree. I think it very much needs to be a core part of the training. And I think what Sandra was saying and what Mark was saying was it's about incorporating it through everything. And as a mental health physician, I'm aware that physical health and mental health are inextricably linked. And when it comes to teaching, you actually have a hard time in separating the two. And then you put that person with their physical health and their mental health on this planet and all the things that go with that. So I think across the board, we need to be thinking in a holistic way. And it's about weaving all of these concepts through every different part of the curriculum.
Yeah, thanks, Niamh. I see another question in there. Chris, maybe I'll just come to you. And the question is, after taking an undergraduate course in global health, how can this be put into practice? And I guess that's a question we get a lot in the Irish Global Health Network with the young professionals coming through us.
In terms of how do you establish a career in global health? And
how do you put it into practice?
Yeah, I think there's a number of different opportunities through. Firstly, within medical electives and international electives, and then just even the range of different organisations that have been presented here, that all probably have entry points for young people to work with them. And I would just say to anyone that's interested in working in this area to reach out to those different networks, because most of them are run pretty thin as well, and actually will want that additional support and that enthusiasm and everything else. So I would definitely just encourage people to do that. And maybe just very quickly on the previous point as well about how do we actually incorporate these themes into global health training. Most of us are very, very lucky to work at huge universities and organizations that have such a range of different expertise and disciplines, and we talk so much about multidisciplinarity and interdisciplinarity, but are we linking up medical students with the other people within the universities that are experts within these different areas? And we talk a good talk on that, but I'm not sure if it happens. And the other thing, which just to the first, it was talked a lot in the first couple sessions about reciprocity. We have these incredible networks as well around the world. Are we connecting students to people within those networks? So for example, if we're talking to medical students in Ireland about climate change, I think there is still a tendency, even though it's not, but there's still a tendency to kind of see this as a future problem, something that's way down the line. Can we connect them to medical professionals that are seeing the impact of it right now? Mm-hmm. I'm sure we can. Yeah. And maybe that would just help kind of connect these different things in a real way for students.
Thank you. Thank you, Chris. Just last words, just coming to everybody for a last word, maybe to you, Sandra, first. And there is a question for you. What can we do as doctors immediately to act on climate change? And maybe just a last word on to everybody from yourself.
Yeah, I think so. Get in touch. There's plenty of work to do. We've got 14 working groups, lots of area themes: air pollution, active transport, healthcare sustainability, community sustainability. So there's work for everyone. There's loads to do. So yeah, please get in touch.
Mm-hmm. Thank you, Sandra. And I love with climate change that it can also start with very, very small things, like just noticing if you're going into a coffee shop, if we were able to, and just bringing a cup with you rather than taking a takeaway. Wonderful. Niamh, to you, please, just any last word as we finalize the session?
Sorry, I always forget to turn off my mute. It's really just to say, emphasizing what Chris was saying there about how you incorporate global health into your working life. I'm very new to all of this. I first came across global health in June and have suddenly found myself here. And it's because of having linked in with people, in particular David Weeklam, Diarmuid. There's 5 people from our subgroup on this symposium here today, and a number of really enthusiastic trainees. So I think just link in with people that have that shared interest with you. Take any opportunity that you can to get involved, and keep talking about it as well, particularly with the anxiety that comes with climate change and all the crises that are facing us at the moment. Make climate friends.
Make climate friends. Thank you, Niamh. Great last words. Coming to you, Frank, just a last word as briefly as possible. Thank you so much.
Thank you very much. Well, I'm not a climate change expert, I'm afraid, but all I would just say is that I think we do need to try and look at giving other foreign doctors an opportunity to train in Ireland and return to their home country. I mean, I think it's fundamentally important we get the balance much better here in Ireland and work in partnership with countries abroad. And actually, it's worth saying we've got great response from Pakistan and Sudan. But I've an affiliation with Zambia. I'd love to see Zambia getting into that circle as well. Dermot and David and I have been very much involved in that over the years. But we're open to suggestions and partnership in relation to that. And thank you.
Wonderful, Frank, and thank you for the work that you're doing. And over to you, Mark. Just a last word as briefly as you can.
Sure. Yeah. Thank you for this. You know, a friend of mine defines global health as a field that exists to decrease the burden of disease worldwide. And the highest burden happens to be right now in low and middle income countries. When we think about global health, we often, even though we say we don't, we often think about it as, oh, this stuff that happens in other countries. Whereas all these competencies that we've been talking about, global should mean global. We should be welcoming researchers and experts from Zambia to come and examine the US or the Irish healthcare system and help with the same barriers to care there. So I think if that would be my final word, would be to encourage people to think about global health in terms of those competencies and less in terms of location where it is.
Yeah. Thank you, Mark, and you're welcome to Ireland. We're glad you're here. And last word to you, Dermot, please.
Again, just to agree that these global things, I mean, if we're talking about equity everywhere, that's right here locally on our doorsteps as well. And just people who've heard me talk before will realize that in the health service in Ireland, very few people realize that there's a public sector duty. We in the health service are supposed to be eliminating discrimination, promoting equality, and protecting the human rights of staff and users of the health service. So there are basic things around rights and equity that we need to be doing right in our everyday work, no matter where we are, everywhere.
Wonderful. Thank you, Diarmuid. Thank you, each and every one of you, for the enthusiasm and the energy and the expertise that you bring to this. And I hope that many people listening have just a better idea of the core competencies, what they are, and how they can maybe do something themselves. So I'm just nothing left to do but hand you back to David Weeklam, who has been mentioned a lot since rightly so. And just over to you, David, to close us out. Thank you.
Thank you very much, Nadine. Yes, so the job for me is just to wrap up and close off. I think we've had a great morning, wonderful speakers, wonderful perspectives. I heard the word used fascinating. I saw someone else write a note, inspiring. I think it has been all of that, and I hope you've all found it interesting and useful. I'm not going to try and sum up anything. I do want to very briefly just extend a quick vote of thanks to the organising committee, ably led by Eric O'Flynn, who did a wonderful job. Thanks to the RCSI for hosting us, and I'd like particularly to thank Erica and the comms team for all their work in helping everything go so smoothly today. And also to thank Nadine Ferris France too for her help with the organisation. And finally, we just to thank all of the speakers and moderators, all very busy people in different parts of the world, giving the time today and just sharing in such a wonderful way with us. So just as we go from here, to say that we will share a report of the conference, and you should get that. And we'll be continuing to engage on all of these things through the work of Global Health Education Ireland, so through the Strategic Working Group, Global Health Working Group, in the forum, and the group that's looking at global health competencies. So if you'd like to connect with us, can you show the previous slide there that just gives the email address? You can get in touch with us, that address, forum@rcpi.ie. So please feel very free to get in touch. And then next slide. And then if you are interested to be part of the global network in Ireland, and you're not part of it, I would very much suggest you join the Irish Global Health Network, which is a very vibrant, active network of people engaged in global health. And you can sign up to that and receive regular updates on global health. And then the last slide, just to say just finally that there are 4 CPD points for this meeting today, for all of those who are interested in that. And with that then, just to finish up and say thank you very much for participating. I wish you all well. Have a good day wherever you are, and let's keep in touch, and well, see you again next year. Okay, thanks.